Can start. We are online now. Thank you.
Good evening, everybody. Welcome to the Expert Crosstalk. The topic for today's uh, discussion is empagliflozin, multi-mechanism, multi-indications, multi-benefits. Today we have two speakers, Dr. S.S. Mohanty. He is an MD/DM cardiology, a consultant interventional cardiologist at SMC Hospital, Raipur. And we have Dr. Shivendra Verma, who is an MD/DM endo with NHMMI Hospital, Raipur. With Without wasting much of your time, let me hand over the session to Dr. Verma. Sir, over to you.
Yeah, thank you so much. So I'll begin. Can I share the slides now?
Yes, sir, please.
Just confirm whether it is visible.
Sir, it
The
is.
slides are,
Yes, sir. So please make.
yeah. So welcome all. Very good evening, and good evening to Dr. Mohanty sir also. We both will be speaking on the latest addition and the remarkable discovery in the recent times, the empagliflozin, the trademark drug of SGLT2 inhibitors. And recently it has shown that it has benefits based on multiple mechanisms. So it has led to multiple indications and with multiple benefits. So I think some changes are there. I cannot see. 1 minute, I'll take some time.
ये खुद ट्रेनिंग नहीं कर रहे हैं क्या? उधर से ना उसका क्या तो खुद करेंगे तब होगा ना. हाँ.
So why is there so much of hype with empagliflozin? So much of talking are there with empagliflozin, and it is one of the drugs, as I said, with is a class of SGLT2 inhibitors. And over the top in this slide, you can see the major trials which have been done with SGLT2 inhibitor. The first one is the EMPA-REG outcome. The first cardiovascular outcome trial, which was done with empagliflozin, then was canvas with canagliflozin, then declared TIMI 58, and credence again with canagliflozin with renal outcome, and latest one with DAPA heart failure trial. So all these trials mostly are CVOT trials were done to assess the cardiovascular safety. However, what we found in these trials, especially in EMPA-REG outcomes, that there was a decrease in the cardiovascular death as high as 38% with confidence interval less than 1. So the all-cause mortality was also decreased. Similarly, there was decrease in the fatal or non-fatal myocardial infarction. This was also similarly shown with dapagliflozin, but EMPA-REG has a more robust outcomes in this sense. Along with this, you can see throughout these class, all these class of drugs are showing reduction in the hospitalization for heart failure. So this is the most different finding with these class of drugs, that this thing, hospitalization with heart failure, which was usually a ignored finding, it was found that this drug was able to produce a significant reduction in the hospitalization for heart failure. And over the next slides, we will discuss this aspect also. And Dr. Mohanty will be speaking specifically for this aspect in even in non-diabetic subjects. So now we are in the era that what are the drugs which are able to reduce the complications? So previously, the basic fundamental approach for diabetic subjects was to achieve a good HbA1c. But now, over the last 2 years, the guidelines like ADA and European guidelines have shifted from the good HbA1c control, which was the prime target. Now they also think of the drugs which can reduce the complication. And this is mainly ascribed to the discovery of SGLT2 inhibitors and GLP-1 analogs. So if you see, the microvascular complications are reduced with the SGLT2 inhibitors, the nephropathy, new onset end-stage renal disease, renal death have all been reduced with the use of these drugs. So the other macrovascular complications like myocardial infarction has also been found to be reduced with the use of empagliflozin in EMPA-REG outcome trial. However, there was a non-significant increase in the risk of stroke, which was not found in other trials. So it was probably non-significant finding. So what are the other drugs? Like these gliflozins have been shown to reduce MI, stroke, death, and heart failure. The empagliflozin, canagliflozin, and DAPA all have shown to reduce the risk of myocardial infarction. Cardiovascular death probably is more robust with empagliflozin. Coming to the I'll be speaking more on the endocrine and diabetes perspective of the empagliflozin. So let's come to the point that how does it act, this SGLT2 inhibitor? So to begin with, there are sodium glucose transporters present in the gut as well as kidney, and most of the glucose is reabsorbed from the glomerular filtrate via the SGLT2 inhibitor, which are present in the P1, the most proximal segment of proximal convoluted tubules. Later on, there are in 10% of the reabsorption also occurs by SGLT1 transporters. And then the glucose passes into the interstitial fluid by the glucose transporter 2, and then it's get reabsorbed. So what are the suggested benefits of the cardiovascular and renal benefits of SGLT2 inhibitors? There have been multiple and plenty. Like if we start that advanced glycation end products mediated effects are reduced, and advanced glycation end products and rate signaling, which are the receptors for advanced glycation end product signaling, is reduced. It does reduce body mass. There is a reduction in the adiposity, and the leptin, which have been the biomarker of adiposity, it is found to be reduced. So there is a reduced inflammation. There is decreased skin sodium content. So most of the sodium which is lost, natriuresis occurs, is from the interstitial fluid. And recently it has been found that the non-alcoholic fatty liver disease is also improved, which also can contribute to the adverse cardiorenal outcomes via causing inflammation. Then the more beneficial effects on the heart is by more production of the ketone body. So there is altered metabolism. There is a decreased sodium hydrogen exchanger, which decreases the cardiac load. And somehow the heart rate has found to be reduced in some of the studies. In some of the studies, there was not significant. So these are the mechanism for the beneficial effects on the heart. Plus, the vascular effects in the peripheral arteries also, because of the good glycemic control, good endothelial function, decrease in the vascular stiffness, and some point of time, some 3 to 6 mmHg decrease in the systolic blood pressure brings about a good vascular benefits as well. Along with that, there are other benefits like decreased plasma volume, and some increased hematocrit and red cell mass increases, which may be secondary to hemoconcentration. Plus, some of the studies have suggested increase in the erythropoietin levels. There is decrease in the plasma uric acid level, which has been indirectly related to the good cardiovascular outcomes. In the kidneys, it causes natriuresis and osmotic diuresis as well. So it does help in preventing the onset of the heart failure. Then there is increase in the glomerular efferent arterial vasoconstriction. So the systemic effect on the glomerular efferent arteries is less, and thus it decreases intraglomerular hyperfiltration. And there is increased glucosuria, so it causes loss of the calories, and then it causes weight loss. Plus, there is decrease in the albuminuria, which is the basic effect, and it prevents the progression of the renal disease. And the beneficial effects of SGLT2 inhibitor may complement and improve the effects of mainstay of heart failure medications. So like the other medications of the heart failure, like ACE inhibitors, ARNIs, mineralocorticoid receptor antagonists, and diuretics, along with SGLT2 inhibitor, they cause natriuresis. So it is complementary to these also. Plus, kidney function, cardiorenal physiology improves. It reduces intraglomerular hyperfiltration, as we have discussed. There is on the heart, it decreases preload, afterload, and LV wall stress, like the other prominent drugs used in the heart failure, and it decreases interstitial edema, which is more robust with SGLT2 inhibitor compared to the diuretics. While diuretics are more in the intravascular fluid loss, this is more in the interstitial fluid. Interstitial edema predominantly is decreased by SGLT2 inhibitors. And over the time, multiple drugs have come as SGLT2 inhibitors. So there is a good strength of evidence regarding. So there have been number of research publications like dapagliflozin published in 2008, and now empagliflozin in June 2010, 12. So there is a good strength of evidence in favor of these drugs also. Let's a little bit discuss about the pharmacological properties. The dosage of these drugs in the three prominent SGLT2 inhibitors are the empagliflozin is given in 10 or 25 milligram dose, usually a starting dose of 10 milligram per day. Dapagliflozin in 5 or 10 mg, and canagliflozin 100 milligram per day. And in very rare situation, when the patient is on antitubercular agents or the effect is not coming up, we can go up to 300 milligram per day. And most of these drugs are given once a day. It can be given with or without food, but canagliflozin before first meal. And usually the peak plasma concentration is achieved very early, around 1.5 to 2 hours later. Their absorption is also in the range of 60 to 78%, which is quite good. And primarily they are metabolized by the glucuronidation. So there is no active metabolite, which is a good thing with these drugs. So no major interactions are there with these drugs. And the elimination half-life is quite long. So their once daily dosage is quite enough. And the selectivity with the empagliflozin is much higher compared to the dapagliflozin and canagliflozin. So in future, if we see some of the adverse effects are more likely to occur with the other agents compared to the SGLT2 inhibitors. However, no clinical data are there to suggest any special beneficial effect of empagliflozin regarding the selectivity. And the glucose excretion with higher dose is around 78 gram per day. And with canagliflozin, since it can be given up to 300 milligram per day, it is much higher. But I would suggest that 300 milligram per day of the canagliflozin dose is quite high. And in fact, it was the more supraphysiological dose even in the original trial. So pooled phase 3 corrected change from baseline HbA1c. So this is the primary effect which we see from the empagliflozin or other SGLT2 inhibitors. How much reduction in the HbA1c it can cause? There are the variable effects with the, and pooled data shows with monotherapy, with metformin, with pioglitazone, or even with the combination of metformin and sulfonylureas, there is a reduction in the range of 0.74 to up to 0.85 when given as monotherapy. And definitely there is a difference when you have an add-on empagliflozin compared to the other drugs. And there is a slightly more benefit when you give a higher dose. However, most of our patients, we begin with the 10 milligram of the dose. But there may be some personal experiences with the doctors that sometimes in some group of patients who are a lot of obese subjects and we start this drug, some patients may even have a much dramatic decrease in the HbA1c, what we expect from these studies. And even in the body weight also, the pool data do suggest there is a significant decrease. It may be in the range of 2 kgs, 1.8 to 2 kgs, but some of these patients may go on to decrease 5 to 6 or even 8 kgs of weight, but it depends on the concomitant lifestyle modifications being advised. So the two good benefits seen with these drugs along with HbA1c reduction is reduction in the body weight, which can be very significant. And in fact, some of the patients may have slight decrease in the systolic blood pressure as well, which may cause some of the beneficial cardiac effects. However, it is not that significant that it can be ascribed a good antihypertensive medications. So this is the ambulatory blood pressure monitoring study done for over 12 weeks with empagliflozin in patients with type 2 diabetes and hypertension. And as we can see with the empagliflozin and with the uh, empagliflozin 10 milligram and 25 milligram, there is a quite a bit of reduction compared to the placebo when it is compared with the blood pressure monitoring. So the mean blood pressures over the 24 hours are significantly lower compared to those who were not on uh, empagliflozin. And this is good that one drug is causing a blood pressure reduction over 24 hours. And similarly, with the diastolic blood pressure also, there is a slight reduction in the diastolic blood pressures seen both with the 10 milligram and 25 milligram dosage. So the benefit is there in both the systolic and diastolic blood pressures. And similarly, in the change in lipids from baseline and up to 24 weeks is found, there is a good reduction in the triglyceride levels. You can see, and HDL cholesterol, not very much, but definitely with the triglyceride levels are uh, uh, much reduced. This is predominantly due to the glucosuric effects seen with these in these subjects, because once the glucosuria is lost, there is a more shifting of the triglycerides in their usage apart from their production from the liver. That's how it causes decrease in the triglyceride levels. And if we can see that the effects of SGLT2 inhibitors on glucose control, body weight, and systolic blood pressures. So I'm not going to tell one by one or each of the lines are there. The good glycemic control, good effect on body weight, and good effect on systolic blood pressure is expected whenever this drug is added, whether it is being added as monotherapy, it is being added over metformin, or even in those subjects who are very obese or on insulin also. So whenever you add this drug, you have definitely a good effect on these three important parameters for overall glycemic control and overall beneficial effects. Another important aspect is the safety of the empagliflozin. So what are the adverse events which we expect from the empagliflozin? So a lot of us are afraid of the common side effects seen with empagliflozin is that balanitis and lower urinary tract infections, cystitis, especially in females, are very common. And some of these patients may have pernicious gangrene or even pyelonephritis. However, when we use in most of our subjects, all these side effects which have been found to be very less, and most of the side effects are very mild. Like some of the male subjects may complain of penile irritation or balanitis, which can be treated with the local use of the drugs like antifungal agents, and you can stop the drug transiently and restart again. There is no harm in long-term continuation. And if we check up the data, what is the data that or what are the adverse events with these drugs? When we compare with the placebo, there is not much difference with empagliflozin 10 milligram or 25 milligram. Almost 70% in all the arms had adverse events. So the adverse events are not these drug related. And the drug discontinuation because of the adverse event is also equal in the three arms. Similarly, the serious adverse events and even the one or more pooling of the adverse events are also almost equal in the three arms. So the adverse events are not higher when we use the SGLT2 inhibitors, empagliflozin in our subjects. They are almost equal. There may be some minor side effects which are mostly treatable. And when we just identify the individual adverse events, so, and we compare, we subdivide into male and female regarding urinary tract infection also. So in placebo also, there was only 19.3% incidence of the UTI, and 20.2 and 20.1% incidence of the UTI. So it was non-significant. Similarly, in males also, there was slightly higher incidence of urinary tract infection in on 25 milligram of dose. So as I said, some of the males may complain of minor infections, which are usually treatable. Pyelonephritis is not much different. So mostly it is safer drug and does not cause pyelonephritis. And similarly with acute pyelonephritis, other urosepsis, other genital infections as well. In terms, the genital infection, which I said like vulvovaginitis, balanitis, they are slightly much more common. And as we go up, it is 1.1% in placebo group compared to 4.7 and 5.6% respectively with empagliflozin 10 milligram and 25 milligram of the dose. And in both the genders, the incidence is much higher. So that's how we should be careful of, specifically of the genital infection. If there is pre-existing genital infection, then we should treat those subjects first, and then we should think of starting, and always give your patient that they should take the plenty of water, specifically when they take the drug. They should be well hydrated. Toilet hygiene should be maintained. Genital hygiene should be maintained. If possible, they should not use the public toilets too often. So that's how you can prevent those genital infections. And when it is about volume depletion, this is one of the theories behind the a non-significant increase in the risk of a stroke, which was seen in EMPA-REG outcome trials. Again, the volume depletion, when was measured accurately, that was not different. So what was probably thought previously has not been found correct, that it does cause volume depletion. And the hypoglycemic events, of course, this is the drug which causes glycosuria primarily. So the risk of hypoglycemia is almost negligible with this drug. So now, as I said, now the theories and use of the drugs have been modified. So now the indication of these good drugs like SGLT2 inhibitors and GLP-1 analogs, they have been enhanced. It is not that you use them primarily for HbA1c reduction. Now their usage is use of these drugs have been widened, and now we will see what is the empagliflozin and cardiovascular outcome in patients with type 2 diabetes mellitus at high cardiovascular risk. So in those subjects who did not have coronary artery disease, but they were at high risk based on the multiple risk factor, what was the outcome? So some of these subjects in EMPA-REG outcome trial, what were the renal outcomes also were there, that the incidence of worsening nephropathy in the empagliflozin group was 39% lesser compared to the placebo arm. Progression to macroalbuminuria was also 38% lower. And if we see the composite of both these outcomes, there was a robust 46% reduction compared to placebo. So these are the number analyzed, total number, which was quite good. So it does decrease the high risk patients. You can easily assume that those who are high risk for renal outcomes, those who have macroalbuminuria or worsening nephropathy, they have adverse cardiovascular outcomes also. So any drug which is preventing the renal progression or decreasing macroalbuminuria has been expected to have good cardiovascular outcome in the long term. And so the finding is in patients with type 2 diabetes and high CV risk, empagliflozin given in addition to routine standard of care, reduced heart failure, hospitalization or CV death is found with a consistent benefit observed in both those with and without heart failure. So even subjects who have a normal ejection fraction, if echocardiogram is done, they don't have any heart failure or no symptoms of heart failure, the benefits are equal. So this should be the priority drug even in those diabetic subjects who have higher risk of later cardiovascular events, though they may not have an underlying coronary artery disease. So, EMPA-REG outcomes, we will again discuss what were the 3P MACE or 3-point major adverse cardiovascular events. So, it has found good significant reduction in the 3-point, that is the composite of cardiovascular death, non-fatal MI, non-fatal stroke. So predominant benefit was found in total cardiovascular death, which was around 38% reduction with confidence interval of 0.49 to 0.77, that is less than 1. There was a slight increase in the risk of non-fatal stroke. However, it was non-significant. Non-fatal MI was also lesser. However, it was not significant to say that it is a superior drug to prevent non-fatal MI. So any patient who had a very high cardiovascular risk, we can prevent significant cardiovascular death in those subjects by using empagliflozin. And how early after treatment initiation are the cardiovascular benefits of empagliflozin are apparent? So this is one of the major benefits with empagliflozin compared to the GLP-1 analogs, that cardiovascular benefits have an early separation of the cumulative incidence curve. So you expect the benefits as early as few months of time of starting the empagliflozin, maybe as early as 2 to 3 months of time, compared to the GLP-1 analogs, which have more cardiovascular benefits at the end of the 1 year. So the benefits are much earlier in SGLT2 inhibitors compared to the other class of the drugs. So benefit of empagliflozin in reducing risk of heart failure, death, hospitalization to heart failure, and CV death. This is composite, emerged within weeks after treatment initiation in EMPA-REG outcome. This is a very significant finding. So now we consider most of the subjects who come with the acute heart failure or acute coronary syndrome episode, we try to initiate this drug as early as possible to prevent the future events. And here you can see that reduction in risk with empagliflozin versus placebo is significant at day 17 for hospitalization for heart failure. So at day 17, the risk with the risk for heart failure was decreased, and at day 27, the risk for combined cardiovascular death and hospitalization for heart failure was decreased. So the benefits are seen within 3 weeks for hospitalization for heart failure, and within a month for combined cardiovascular death and heart failure. So this is the drug which should be considered to be started as early as possible after the event. And what do guidelines suggest? Based on these 2018 ADA and European consensus reports, metformin not necessarily considered a first-line drug therapy still, but most of the guidelines are still making it as a first-line drug. So I would suggest we should still be using metformin in most of our subjects. And drug-naive patients or patients on metformin, irrespective of level of HbA1c, if they have atherosclerotic cardiovascular disease, we should consider starting SGLT2 inhibitors or a GLP-1 analog. Or even if they are high risk for cardiovascular disease, they should be started on one of these drugs like SGLT2 inhibitors or GLP-1 analog. So in a clinic, when a patient comes who had established cardiovascular disease, which can be judged by a simple ECG, a history of chronic stable angina, history of hospitalization for heart failure, or even history of acute coronary syndrome, they should be considered for SGLT2 inhibitor first line. Or if you find they have a multiple risk factor, like they are a smoker, they have high cholesterol level, they are obese, then also you consider this SGLT2 inhibitor as a primary drug for the treatment of diabetes and to prevent the cardiovascular risk. Now with this, I end the diabetes and endocrine part of the empagliflozin. I'll hand over to Dr. Mohanty to speak on the benefits of SGLT2 inhibitors even in non-diabetic subjects regarding the heart failure, and he will be speaking mostly on Emperor trial, if I'm not wrong. Over to you, sir.
Okay, thank you, Dr. Shivendra, for a nice lecture on the endocrinal perspectives of empagliflozin. Good evening, everyone, and welcome to this topic of empagliflozin in the cardiology perspective. Slides are visible. Okay.
Yes, sir.
Now, exploratory data. Yes. It is visible and I am audible?
Yes, sir.
Okay. Exploratory data shows that SGLT2 inhibitors have multiple cardiorenal benefits. Different trials on different SGLT2 inhibitor molecules have shown that there is consistent reduction in heart failure hospitalizations, reduction in cardiovascular death, and improvement in renal outcomes. In all these trials, empagliflozin has shown consistently there is a benefit of more than 35% in all the three parameters as compared to CANA, DAPA, and empagliflozin. This is EMPA-REG outcome. I think I need not talk on this because it is already elaborately described by Dr. Shivendra. And this is a trial, positive trial, which has shown that there is significant reduction in cardiovascular death from any cause, and hospitalization of heart failure with empagliflozin 10 and 25 milligram. From the Framingham study, it has been seen as the duration of diabetes increases, the risk of heart failure increases. Also, as the age increases, risk of heart failure increases, and the risk of heart failure is more in female sex. In all these trials where the diabetic patients, it has been seen that the most common outcome is heart failure as compared to MI, stroke, and death. Comparing intensive glycemic control to less intensive glycemic control, these four trials, ACCORD, ADVANCE, UKPDS, and BADT, it has been shown that it favors intensive control in reduction of myocardial infarction, and most of the trials has shown favor for intensive control arm in reduction of hospitalization for heart failure. This slide shows that the hazard ratio is lowest with empagliflozin, SGLT2 inhibitors, and GLP-1 analogs and insulin as compared to thiazolidinediones and DPP-4 inhibitors, which indirectly says that these are the most beneficial drugs so as the cardiovascular risk is concerned. So there is multiple mechanism of action and multiple benefits of the SGLT2 inhibitors. They cause natriuresis, they reduce preload, reduce afterload. Also, they reduce the LV wall stress. They selectively and more reduce interstitial edema as compared to diuretics, as Dr. Shivendra has already elaborated. Also, they improve renal function and cardiorenal physiology. Drugs that prevent only heart failure are statins, antihypertensive drugs like diuretics, SGLT2 inhibitors, weight loss, and therapies that are only for established heart failure therapy are ARNI, ivabradine, CRP or ICD, and mineralocorticoid receptor antagonists. And therapies those both prevent and treat heart failure are ACE inhibitors and ARBs, beta blockers, and lifestyle modification. What guidelines speak? 2019 ESC guidelines, they have recommended that metformin is not necessarily considered to be the first-line drug of therapy. In contrast, ACCHA practical guidelines 2019, they consider metformin is the first line of therapy. In European guidelines, irrespective of the hemoglobin A1C level, if the patient is having established atherosclerotic cardiovascular disease or is a high or very high risk of cardiovascular disease, then SGLT2 inhibitors or GLP-1 analogs should be started or added to metformin. Whereas in ACCHA guidelines, if the hemoglobin A1C is more than 7% and the patient is having high cardiovascular risk, then consideration can be given for initiation or combination of SGLT2 inhibitors with metformin or GLP-1 analogs. Emperor heart failure study. This is a study. It has two components. One is Emperor reduced and the other is Emperor Preserved. Emperor Reduced is a study where the patients were taken where the ejection fraction is less than 40%, reduced ejection fraction, and Emperor Preserved means the ejection fraction is more than 40%. This study is not yet completed, about to be completed in April 2021. From the Emperor Reduced study, what we have seen, 3,730 participants where placebo is compared with empagliflozin 10 mg, followed up for a period of 16 months. These are the areas where the patients were enrolled, and these violet stained areas, patients took part in both the studies, both in Emperor Reduced and Emperor Preserved, whereas in blue stained area, it is only patients for Emperor Preserved study, whereas areas with red, it is only in patients for Emperor Reduced study with patients having heart failure with reduced ejection fraction. Regarding the mechanisms that is responsible, such as striking improvement with the beneficial effect of SGLT2 inhibitors in heart failure with reduced ejection fraction, it has been seen that these molecules, they increase fasting levels of ketones, thereby utilization of efficient metabolic fuel in the failing heart. However, in experimental studies, this option is not consistent and the hypothesis is not supported. But it is proposed that SGLT2 inhibitors slow the course of cardiomyocyte injury by inhibiting sodium hydrogen exchanger 1 in the myocardium, who leads to intracellular sodium and calcium increase, thereby impairing cardiomyocyte function and viability. Thus, empagliflozin has been shown to inhibit the calcium and calmodulin dependent kinase 2, which contributes to the activation of NHE1 in the heart. Thereby, indirectly inhibiting this NHE1, empagliflozin protects cardiomyocytes. And it has been shown to prevent the time-dependent decline in systolic cardiac function in experimental pressure overloaded induced heart failure. Coming to the Emperor Reduced trial in detail, this trial specified only 3 endpoints to be tested in hierarchical manner. The primary endpoint is composite of cardiovascular death or heart failure hospitalization. The first secondary endpoint is total heart failure hospitalizations, which include the first hospitalization and recurrent hospitalization for heart failure. And the secondary endpoint is slope of leak time in glomerular filtration rate over time. This trial has shown superiority to placebo in improving heart failure outcomes among patients with symptomatic stable heart failure with ejection fraction less than 40%, who are already on guideline-directed optimized medical therapy, irrespective of status of diabetes. This is a 1:1 fashion to either empagliflozin 10 mg or placebo in almost 3,600 patients. Duration of follow-up was 16 months. Mean age was 67 years and 24% of patients were female. All were above 18 years. Chronic heart failure stable patients with class 2, 3 or 4 NYHA symptoms. Left ventricular ejection fraction was less than 40%. History of heart failure hospitalization within 12 months, and NT-proBNP level more than 600 milligram if ejection fraction is less than 30%, more than 1000 picogram per ml if EF is 30 to 50%, and more than 2500 picogram per ml if ejection fraction is more than 35%. And this level is doubled if the patient is having concomitant atrial fibrillation like proBNP 1200, 2000 or 5000 in less than 30 to 35 and more than 35 ejection fraction. Exclusion criteria, all the patients who are having ACS, stroke or TIA within last 3 months, they were excluded from the study. Patients on transplantation or left ventricular assist device, patients with hypertrophic or infiltratory cardiomyopathy or peripartum cardiomyopathy, they were excluded. Patients with severe valvular heart disease, decompensated heart failure, or patient receiving ICD or CRT within last 3 months were excluded from the study. The mean left ventricular ejection fraction was 27%. Functional class 2 patients were 75%. Diabetes almost 50% patients. Estimated GFR was less than 60 in 48% of patients. And in medications, maximum number of patients were on beta blockers 94%, followed by mineralocorticoid receptor antagonists 71%, followed by ACE inhibitor ARB 70%, and then comes around 19% was ARNI. The principal findings of the study was that primary outcome, that is cardiovascular death or heart failure hospitalizations, was significantly less in the group where empagliflozin 10 mg was used as compared to placebo, and there was non-significant reduction in cardiovascular death or heart failure hospitalizations. Thus, SGLT2 inhibition with empagliflozin is effective in heart failure with reduced ejection fraction with or without diabetes, as 50% patients in this study were not having diabetes. So there is a 25% reduction in composite of cardiovascular death or heart failure hospitalization, 30% reduction in first secondary endpoint, that is total heart failure hospitalization, and 50% reduction in the slope of declining glomerular filtration rate over time. This is the same thing in graphical pattern. The significant benefit in reduction in cardiovascular death or hospitalization for heart failure and composite renal endpoint. Thus, the implications of this EMPEROR-reduced trial in clinical practice, that empagliflozin have a major impact on management of patients with chronic heart failure and reduced ejection fraction, whether they have diabetes or they don't have. But it has got a very major beneficial impact in heart failure reductions. So there is a compelling evidence that SGLT2 inhibitors should now be added to currently recommended treatments for this disease. Primary and secondary cardiovascular outcomes, the same thing, this significant reduction in hospitalizations for heart failure and death from any cause. Same thing. Total hospitalizations for heart failure, fast heart failure and recurrent heart failure, there is a significant reduction from 553 events to 388 events as compared to placebo and empagliflozin, and the hazard ratio confidence interval is less than 1 and p-value is very much significant. Regarding this safety of this molecule, it is already elaborately described by Dr. Shivendra, so I am not going to the details of it. Secondary outcomes, total hospitalizations are reduced significantly. Composite renal outcome is also significantly reduced. All-cause mortality, there is no significance, though there is a numerical reduction. New onset type 2 diabetes among patients with pre-diabetes, also there is a numerical increase, but it is not significant. Change in hemoglobin A1C level between baseline and 52 weeks patients with diabetes, it is a significant difference. And systolic blood pressure, there is a reduction, but it is not significant. And hypoglycemic events are not very much significant as compared to placebo. Thus, the result of this trial indicate that empagliflozin is superior to placebo in improving heart failure outcomes among patients with symptomatic and stable heart failure with reduced ejection fraction less than 40%, who are already on excellent guideline-directed medical therapy, irrespective of the diabetes status. So, major benefit is primarily by reduction in the heart failure hospitalizations. Also, there was a benefit in improvement in renal outcomes. This is a very important trial, and it mirrors the similar findings that has been received from DAPA-HF trial on dapagliflozin. Though SGLT2 inhibitors were introduced as type 2 diabetes management drugs, the results of EMPA-REG outcome trial and this EMPA trial indicated a clear benefit in patients with heart failure, whether they have diabetes or they do not have. If the patient is having high risk for heart failure or high cardiovascular associated disease, this medication should be prescribed as first-line drug. This drug will have a prominent role in future heart failure management guidelines. Are SGLT2 inhibitors the future of heart failure treatment? Of course, the EMPEROR reduced trial has shown this, and EMPEROR preserved trial results will come in April 2021, and we hope this will also have a beneficial effect, and it will recommend the same thing what EMPEROR reduced trial has shown. Speculated mechanisms of benefit of this molecule that it reduces cardiac preload, reduces afterload, reduces myocardial wall stress, shifts the ketone metabolism as a positive energy substrate, adaptive cellular reprogramming, inhibition of sodium-hydrogen exchange, thereby protects the cardiac myocytes, improves endothelial function, and reduces cardiac fibrosis and apoptosis. Thank you. Question I have.
Any questions are there? Hello?
Certainly.
Sir, nice presentation.
Thank you.
I don't think so any questions are there. Sakleen?
Yes, sir. Sir, I'm just posting a question. Just allow me 30 seconds. I'll just post a question. The questions, sir.
Okay.
Sir, I've posted questions. Sir, please address them.
Acute pancreatitis. चला गया. Equality and bind up in glycemic control.
Can you just repeat?
Sir, I have posted question in the chat box. Please address them.
Yeah, 1 second. The chat box, I have to just find out where it is. Yeah. 1 second. So regarding the first question, can we prescribe SGLT2 inhibitors uh, without established CVD or having multiple CV risk factor, uh, that is the personal choice. It is not in the current guidelines. Even the 2020 ADA and European guidelines, they suggest that you can use it even as a first-line drug with established CVD or those with multiple CV risk factor. The CV risk factor you can calculate based on multiple calculators like Framingham risk score or ASCVD risk score. However, if those patients who have simple diabetes, the benefit of adding SGLT2 inhibitor is not that great compared to the other drugs. So definitely the beneficial effect is not much. So in that case, it is individualized. You can choose to use this drug based on other indication, like the patient may have non-alcoholic fatty liver disease, patient may have obesity. So these are your individual choices, but the benefit would not be that robust. Then recent FDA warning has come for acute pancreatitis. As of now, no significant uh, pancreatitis risk have been found. There may be some occasional anecdotal reports with acute pancreatitis, which is like similarly with pioglitazone has been shown to have bladder cancer, which was later refuted. So you can still use this drug as SGLT2 inhibitor. We have to wait and watch what is the risk of pancreatitis with longer term use of SGLT2 inhibitor. But you can see that the dapagliflozin was introduced in 2008, so it has a 12 years of use. Then Empag trial, REC trial came in 2012-13, so again it is also 8-year older drug. Still, we don't have a significant risk of acute pancreatitis. So they have given warning, we should be careful, especially those with history of acute pancreatitis. And opinion on remogliflozin, is it equal with EMPA and DAPA and good glycemic control and CV benefits? See, it is not my personally I cannot answer, because the CV benefits can only be answered by a dedicated cardiovascular outcome trial, which unfortunately has not been done with any remogliflozin trials. For glycemic control, yes, most of the studies have said that the HbA1c reduction was almost equal to the other SGLT2 inhibitors. So for glycemic control, it is good. But if you ask me whether it has good cardiovascular benefits, there has been no dedicated CVOT trial. Then is there any clinical trial with specific Indian patient with EMPA? If you see, the sir has presented the Emperor trial, in which both the patients of reduced ejection fraction and preserved ejection fraction were also taken from India. Even in some of the studies with the empagliflozin, some of the patients were there from the Asian ethnicity. Now, this is a drug which is there used in the multiple center across the globe. So you will find that some of the patients will be there from Indian ethnicity, Indian origin, or from India as well. So definitely the Emperor trial had a good number of Indian patients. I'm not sure about Emperor outcome trial, whether how many patients were there from Indian origin, but definitely Emperor had Indian patients. And is there any chance of bad effect on bladder after using empagliflozin? Most of the effects have been regarding the UTI, pyelonephritis, genital infections that have been already discussed in the previous slides. If you ask me bad effect on bladder, could you please specify what do you mean by the bad effect? Is it like bladder cancer you mean, or some of the other things? As of now, empagliflozin per se may cause slight increased risk of genital infection, not very high risk for pyelonephritis or other UTIs. As of now, this is from the literature. I'm not sure whether any particularly specifically you are asking about bladder.
Nicely answered, Dr. Shivendra.
Thank you,
There
sir.
are 19% of patients from Asia countries in Emperor trial.
Any other questions, Aklan?
Okay.
Thank you so much, doctors. So we can't see any upcoming questions. So with your permission, should we conclude the session?
Yes,
Yeah.
yes. Thank you so much. Thank you, sir, for
Thank you.
joining
Thank
this
you.
session.